Welcome everyone to the Older Adults Falls and Concussions Summit. There are still people joining in, so I will start and you will see as others are joining in, we're expecting a few more people. My name is Hélène Gagné. I'm from Parachute and I'm co-chairing this event today with Judy Gargaro from the Neurotrauma Care Pathways Project at University Health Network, and we're both located in Ontario. We would like to acknowledge CIHR for supporting this summit, as well as the planning committee members that you see on this slide. A big thank you, particularly Michelle, who did a fair bit of organization for this summit. Next slide. I'm gonna go over a few housekeeping items and next, but while I do that, we'd love to see who's joining us today. If you can, please let us know your role, organization, and location. Feel free to provide also land acknowledgement too. It's so you can see the website located on the slide. For instance, I'm located in Toronto. I would like to acknowledge the ancestral land of the Wendat, the Haudenosaunee, and a Confederacy, and the Anishinaabe Nation, including the Mississaugas of the Credit First Nation. Please feel free to introduce yourself in the chat. Next slide. Okay, time for housekeeping. It's a busy slide, but I'll go through the components. So first, you'll probably noticing that you're muted. So use the chat or raise the hand if you need to get our attention. You can also unmute yourself if necessary, but we ask that you remain muted, especially during the first portion of the summit. Of course, we'll want you to be unmuted during the breakout room portion and as well as the consensus portion of the summit. So today, and particularly during the breakout rooms and consensus building, we ask you to leave your camera on during those times for those, so we can have a discussion, and if it's available to you especially. But during the breaks, make sure to unmute to mute yourself and turn your camera off, and we will tell you when the breaks are coming up. The summit is being recorded, however, not the breakout rooms, but there will be a facilitator and potentially a note taker in your breakout rooms. So stay tuned. You'll receive a summary of today's event via email in the coming weeks. When the Zoom event ends, a post-event survey will pop up in your browser automatically. The survey will take no more than 3 to 5 minutes to complete, and we really appreciate the feedback, so we encourage you to fill it out. Next slide. If you have tech-related questions or comments, please use the chat. For any other questions or comments related to the content and the topic or the discussions of today, we will be using Slido. You can access Slido throughout the summit to ask questions and see what other participants are asking. So there might be similar questions. You can access this event on Slido using the QR code that you see here on this slide, or by going to the website, which is indicated on the slide as well, which is www.slido.com. And make sure to enter the code, which is 9461618. But you see that at the bottom of most of the slides as right now. The Slido, and most of the slides will have it. So you receive in your meeting package a somewhat of an agenda. This is just a brief overview of how we're going to proceed throughout the summit. So the first part is having presentations followed by a break. Then we'll have a first small group discussion, part 1. We are likely to stay in the same similar small group for that break between the two discussions. So the first discussion focuses on needs and gaps, and the other one goes into finding for solutions. So we will stay in the same groups. And then after that, we will finish with a consensus building and priority setting discussion. We hope to wrap up today by 3 p.m. Eastern, if not before. Next slide, just a quick reminder of the summit objectives, which I believe you received in your package as well. So today we hope to understand information needs of practitioners, clinicians, and decision makers to screen, assess, and diagnose concussions and TBIs in older adults resulting from a fall. And we also hope to identify opportunities and priorities for action to address these needs, as well as identify needs for clinical support resources, tool, and knowledge products to inform practice around concussion, MTBI, in older adults resulting from a fall. So I will now pass it on to Judy to introduce the presentations.
Thanks, Hélène. Good morning, everybody. So the purpose of today, we're going to sort of take you through a bit of a trajectory as we set the stage for our discussions later this afternoon. So obviously the first step is awareness and recognition of concussion. And as you can I think most of us know there's some room for improvement in that area. And then the next stage after that recognition is an accurate assessment. And again, there's some room for improvement in that area as well. And then what we're hoping to get to, and we will get to, are recommendations and actions that we can do to sort of promote recovery. But there's a clinical component to that. There's a research component as well as a government component. So these sort of three, I guess, trajectory elements also fit nicely if we think of our clinical care pathway. So as Hélène said, I'm representing the Neurotrauma Care Pathways Project, and we have developed an evidence-based ideal care pathway. I'll talk to you about a little bit about that later on. And these are the four elements of that pathway. So if we think about how we're mapping our activities, clinical activities, in that pre-acute, we have the setting of the injury. So that's where awareness and recognition needs to happen. If we think of the acute side, that's where accurate assessment needs to occur. And then we have specialized management and time in the community, which obviously time in the community is the largest amount of time. That's where there need to be recommendations and actions to optimize recovery. And these, as I mentioned before, relate to clinical activities, but also sort of structural activities to build the system so that we're optimizing recovery. And those arrows show that things are not always linear, that people can go back and forth at different times. So as much as I could tell you about what things are like on the ground of an older person experiencing a concussion, I'm really can only do so much. And I think it's better that we hear from a person who has lived experience. So I did see that Trudy was able to join us this morning. So what I'm going to do is Trudy does a very good job of introducing herself in the video. So I'm going to play a short video, and Trudy's with us. So I think if there are any questions that you specifically want to ask Trudy, I think we have a few minutes. We can maybe answer those questions. So I'm just going to start this off, and we thank Trudy an awful lot for being prepared to share her story and be with us today.
I'm here because my husband got 2 concussions at the age of 66. Had he been under 65, I wouldn't be here because there would have been all kinds of help. But there were many, many, many places that said they would not accept a referral for someone over 65. As a result, I became a navigator and a caregiver, and my frustration with the system and my effort to make a difference, I joined the Ontario Neurotrauma Foundation. I worked with Health Quality Ontario, and now I am a collaborator on a CIHR grant looking at older persons with brain or spinal cord injury. I know it's fair for you to say, who am I to say why we need a symposium on seniors with concussions? Let me tell you that I had a long career as a social worker, providing direct service and advocacy within the child and youth in need of protection system and for adults adjusting to blindness. I left my social work career and went to work for the Ontario government as a senior policy advisor, working in transforming systems and service delivery in multiple ministries, especially child welfare, special education funding, and the Ontario mental health strategy. I retired as a senior policy advisor in May 2016, and I plan to start consulting. However, in June 2016, my life was torpedoed by my husband's diagnosis of concussion at the age of 66 while I was away in Newfoundland. It took all of my time, skills, knowledge, research, networking, advocacy to get him the right care in Toronto. In Toronto, despite being urban with lots of services, a family physician, and at the same time trying to manage his conditions and becoming a caregiver myself. The difficulties that I had, and as a result, he suffered from, was that despite everything in Toronto, there was no concussion system for seniors. I have no idea what other people do. There was no referral system. There was no easily findable evaluation of what services were effective, what was evidence-based. There were tons of services on the internet, but I didn't know which ones to choose. And there was no coordination or advocacy other than my own. The ABI network at the time was not funded to support persons over 65. His care ended up being significantly delayed because we didn't know who to go to, and it compromised his life and definitely mine. I kept a log of everyone and every service that I called or learned about and every appointment we went to, and it's critical because there was no way that he remembered anything, and I could not keep track of where we'd been, who'd said what, and how his conditions kept changing. As a result, in September of 2016, he was readmitted to hospital with worsening conditions. So when he was admitted in September of 2016, he was there for a couple of days, and there was a hospital neurologist who was coordinating both his assessment, diagnosis, and what he needed. It was amazing. And it was also incredibly useful that I had done all the research and I had names and places that I thought would be best for my husband, and the neurologist agreed with me. So I had made up my own system. I also learned that I had to take a copy of medical reports to every single appointment because there was no coordination. Often the report from one person did not get to the new person we were going to. So I walked around with a binder. It also tracked all of his conditions and symptoms, and I couldn't remember anything at that point because everything kept changing with his condition. I will tell you that we got good service, that the best services, which some took 6 months, some took 18 months, but we got to cognitive neurology, we got to a balance OT specialist, we got to a geriatric psychiatrist, and his GP was amazing, although he really didn't know a lot about concussions and certainly not about who to send him to. I will say that my husband improved significantly, but then, as life tends to happen, his condition worsened after a car accident in 2019, and now both our lives are changed forever. So as a result of the experiences that I've had in trying to get my husband help in learning to live with his limitations and becoming a caregiver, I also channeled my frustration and fury, I must admit, into becoming an advocate for a senior concussion system, pathways, care, and data. In 2017, I joined the Concussion Advisory Committee of the Ontario Neurotrauma Foundation, and I pushed for a focus on seniors. I knew that children and athletes have gained public attention and have funding, some funding, for improved assessment, diagnosis, and treatment. Not enough prevention, but at least there's people out there who are, let's call them heroes, who advocate for them, but there is no hero advocating for seniors and concussion. I knew that ageism reduces expectations for recovery, and without advocates, care is often not provided. They're old. Why bother? It's not acceptable. I knew that seniors who fall are often not assessed for concussion, especially if they didn't hit their head. And this is despite the fact that families or friends are saying, my mom, my cousin, they're not the same. There's something wrong. And it's not about the broken hip or whatever other physical manifestations occurred as a result of the fall. I know that from my policy experience at the government in 4 ministries, that if you don't have data, you are not going to get improved policy and funding. So we have to get assessment and diagnosis. Our senior concussion data is woefully inadequate to push for any change. I will say that the gray tsunami is here, it's growing, and we deserve the best medical care possible for the rest of our lives. So I urge all of you participants, push for a senior system, to push for assessment and all the rest of a care pathway, because we need you. We need you, the experts. Thank you. I'm here because
I'm muted. Sorry. Thank you, Trudy, very much for your story. And I think you really covered the waterfront very well, and you've really highlighted the gaps and the challenges that are in the system. I'm going to take a few minutes to just talk about some incidence data for fall-related concussions in older adults. And so I'm the manager of the Neurotrauma Care Pathways Initiative, and all the data that I'm going to be referencing as part of this is available in administrative databases. And as Trudy alluded, there's a lot missing in those data bases. So this is just simply the best we can do currently with administrative databases. I know there's people on this call who are from across Canada. And so I'm sitting in Ontario and I'm looking at the administrative databases in Ontario, but I've also looked at the national data, and I think the Ontario data is pretty indicative of the way it is across the country. Usually when I ask this question of how many people sustain a mild TBI every year, people generally get it wrong, I have to say. And these are only the people that we know about in the system. So we know there's a large group of people that we're not even seeing in administrative databases. So these numbers, let me wake up my mouse, these numbers are only the people we're seeing. So in Ontario, there's 164,000 people a year, and about 20,000 will go on to have persisting symptoms. And about 15% of this are folks over 65. Complex mild, the way we defined them in our data, is folks who were admitted to hospital for 1, 2, or 3 days. And so there were folks in this who had a diagnosis of concussion that they didn't lose consciousness. So they would be in hospital 1, 2, or 3 days. And notice that almost half that sample are people over 65 years of age. If we want to look at incidence just for folks between 65 and 70, it's 800 per 100,000. And then when we get to those folks over 80 years of age, it's getting close to 2,000 per 100,000. And this is compared, if we take the average across all age groups, of 1,244 per 100,000. And if we look at that complex mild group, you can see there's 29 per 100,000 in the younger, older group. And when we get into the older group, it's about 90 per 100,000. And this compares to 15 per 100,000 when we look across all the age groups. So when we look at how people get injured, when I ask this question, most people get it wrong as well. And I think, notice there, falls, falls, and falls. So when we look at concussion, when we look at complex mild, and when we look at moderate to severe, falls really are the largest piece of the pie. And this is something that it's important to raise awareness about, to make sure that we get that proper recognition and assessment of concussion. So this is some data that I'm going to share with you that my colleague Laura Langer has published, and she also did some data analysis of the cohort where I got the data on the previous slide. And so basically this is a super busy slide with a lot of small writing, but the take-home message here is that older adults have a high incidence and they also have an increased risk. The odds ratio is 1.63 of having persisting post-concussion symptoms. So that's really the take-home message from this slide. And again, this is just another representation of the incidence. So I think people, when they think concussion, they can think of younger kids falling and teenagers doing silly stuff and younger people involved in sports. But you can see we have a U-shaped graph. So we really cannot forget the group of people over 65 years of age. So if people get inpatient rehab, and obviously after a concussion, it's not common that people would have inpatient rehab, but if their clinical situation warrants it, does age influence what type of rehab they get? Well, the answer is, if we look at older persons with a complex mild injury, so these are folks who've been in hospital for 1, 2, or 3 days, they're actually more likely to receive inpatient rehab proportionally than their younger counterparts, but they're more likely to get a general or generic rehab. They're less likely to get specialized brain injury rehab or even a mixed neuro rehab. And again, speaking to some of my clinical colleagues, this is often because of the perception of the need to have a more geriatric focused rehab rather than brain injury specific rehab. If we look at how many older persons have follow-up with primary care after discharge from acute care, so these are folks who've had no inpatient rehab, they've just had acute care, either an ER visit. So if we look at clinical practice guidelines, there's a strong recommendation that within 14 days of your injury that you would be followed up. And less than 2% are followed up within 14 days of discharge. So as a system, we are not doing a good job in general, but particularly not for a group of older people in implementing this best practice recommendation. Things look better at 30 days and they look not so bad at 90 days, but think about this. What we know about concussion is getting the right care early on makes a difference to recovery and not developing persisting symptoms. 90 days is an awfully long time to go before there's a follow-up with a primary care provider. So and again, this is just another example of how the skew is greater for generalized rehab as we get older. And this one here, if we want to look at the percentage who are followed up by primary care for any reason, but not mental health, any other reason, within the first year following injury, I have to say the group 65 and older are the top 2 lines. So that's not too badly in terms of being followed up once, as you saw, within 90 days, it was pretty high. So it's not too bad. In fact, it's the best. But if we look at the percentage that had a mental health related visit with their primary care provider within the first year, it's a bit middle of the pack. And that's, if we look at the percent, that's not very much, around 10%. And again, if we look at the percentage of follow-up with a specialist physician in the first year following concussion, and these would be people who did not have any inpatient rehab, so primarily concussion that didn't require any acute care. The group who are 80 and above, you can see they really are not getting followed up by a specialist physician at all. The 65 to 79-year-olds, they're actually that top line. So there's a real division here between the younger, older group and the older group. And again, if we look at the percentage of follow-up with a psychiatrist in the first year following concussion, so we can see there that the 65 to 79 and 80 plus, they're sort of in the middle of pack. But if you look at the y-axis, you can see that that's not really exceeding 10% of the group. So if we look at functional improvement as measured by the FIM, so for those of you who are clinical, you know what the FIM is. This is a standardized tool that's used across Canada. And for anybody who gets into inpatient rehab, and even for those who get outpatient rehab and some community-based services, their functional improvement is tracked using the FIM. If we look at this, I think the take-home message for you to see here is the slope of the curve. And so clearly the slope of the curve for folks who are older is pretty similar to those of the younger folks, and they're making equivalent gains of younger folks. So the perception that older people do not do as well if given rehab doesn't seem to be held up by this data. So just in conclusion, older adults are at a greater risk of concussion compared to younger adults. They have lower rates of acute follow-up care provided by their family physician and overall follow-up with specialized physicians, especially if there's a need for mental health care. And though they're more likely to be admitted to general inpatient rehab following concussion, potentially due to sort of more comorbid injuries, they have similar rate of improvement on the FIM as younger adults, and more specialized rehab following injury is suggested as possibly being more appropriate from this data. So I've referenced the neurotrauma care pathways, and the point of this talk is actually not to go into detail about that. But I think if you put the data that I've shown you together with what Trudy said, care quality really varies for people we know regardless of age. But when we get to older people, we can have issues of mixed diagnoses due to bias about typical causes of concussion. There's limited availability of publicly available specialized management supports. There's lack of navigation to appropriate community services and supports. And really the care model and access is determined by your funding, whether it's public or third party through insurance. And these variations become huge magnified chasms for folks who've been traditionally marginalized. And so this is where we get issues of bias and isms. So we've talked about, Trudy referenced ageism. So this is an example. So this work that is couching all of what I'm speaking about today is funded by the Ontario Ministry of Health, and it's been funded to develop ideal care pathways based on evidence and lived experience and consensus for concussion, moderate to severe TBI, and traumatic spinal cord injury. And again, the purpose of this talk is not to go into the guideline, but you'll recognize the pathway, you'll recognize that little diagram that I showed up at the front. Underneath each of those stages of care, there are building blocks of care, and there are guidelines, links to guidelines within each of those within each of those building blocks to provide information around the type of care that needs to be provided in order to have that standardized benchmark care for all. So there's a QR code there if you're interested, and we also have a website. So if we want to look at how older persons are represented in the pathway, there is not a separate pathway for older persons. The expected standard of care applies to all, regardless of age, regardless of background. But we do highlight the fact of that at each stage to draw attention to biases and isms. So ageism being one, and there could be racism and all sorts of other isms and biases that operate even in terms of cause of injury that need to be addressed at every stage of care. So guidelines are providing the details of the specific clinical actions that should be taken, and they've historically been silent regarding older persons, but increasingly they're adding recommendations that are delineated by age as research evidence is becoming stronger. So I want to just call out two guidelines. So there's the Living Adult Concussion Guidelines, and Dr. Sean Marshall is the head of that, and you'll hear from Sean later in the day. And as much as we're talking about concussion today, I also wanted to give a little shout out to the Canadian Clinical Practice Guidelines for moderate to severe TBI. And so the funder for this work is the Ministry of Health and Long-Term Care in Ontario, and the Living Concussion Guidelines are supported through the Ottawa Hospital, and the moderate to severe through UHN, and also INES in Quebec. So this is just, again, a QR code to the concussion guidelines, and they also have a website, concussionsontario.org. And I'm not going to go into too many details, but I encourage you to go to the website. The purpose of this is really just to show you the scope of the concussion guideline. So there's chapters that are here. And so all of this is relevant to anybody from any age, and you can go within this and you'll get a summary of the evidence, and you'll get recommendations. So these are living guidelines, and I just want to call out that one of the exciting things that happened last summer was the release of the ACRM diagnostic criteria. And this was really an effort by the American Congress of Rehabilitation Medicine to really clarify the criteria that should be used in the diagnosis of concussion. And the guideline was able to adopt this immediately into their recommendations and their work. And so again, I'm not going to go into the details of these criteria here, but just to say that there are 6 very clear criteria that need to be met in order to have a diagnosis of concussion. And there's nothing here specifically delineated for older persons, but all of these criteria are relevant. And so, for example, criterion 1 looks at a mechanism of injury, plausible mechanism of injury, and falls would definitely fall in this. Yet it is very common that an assessment of concussion does not occur after a fall, especially if the person hasn't hit their head. The one thing I would highlight is criterion 6 is when what you're seeing, your clinical signs and symptoms, are not better accounted for by other factors. And I just caution here that we have to make sure not to fall back on biases and ageism when we are applying criterion 6. So what I'm going to do is well, one more slide, sorry. So there's not much that's older person specific, but really all the recommendations are relevant within the guideline. But I'm just put an example here of the type of content that's starting to be delineated for older persons when there is research evidence to support it. So this is a recommendation around insomnia, and to talk about how it's prevalent, very common, in general, and older patients and those of female gender are at increased risk. So this is an example of the type of age delineated content. So there's a couple of relevant research projects I'm just going to mention very quickly. There's a CIHR grant. There's a concussion in older adults report that was done from the BC Injury Prevention Research Group. So there's a link there, and they found at the time when they did that prevalence of concussions in elderly and the potential impact on morbidity and mortality, as well as general quality of life. More knowledge is required to guide the protocols and best practices around caring for seniors with concussion. There's a CIHR funded that I'm involved with, where we're really trying to look at what policies are needed to optimize system design for people living with the effects of traumatic brain injury and spinal cord injury, but I'm highlighting here traumatic brain injury and aging, to ensure equitable and integrated access to specialized regional care providers. And so we're going to be doing this by synthesizing qualitative and quantitative data. So we've done a review of the literature. We're collecting some data over a 10-year period of time, and we're collaborating with people with lived experience to create a policy brief. There are also some relevant clinical initiatives to all this. I apologize for my spelling mistake. I see that now in the title. There's an echo concussion, which includes a session that includes concussion recognition and management for older people. The Canadian Concussion Network had a panel discussion at their 2023 annual conference in Calgary. And there's an increasing focus on healthy aging in place by governments in their strategic planning. So I think what's important to notice is the strategic planning is sort of pointing in this direction, but we need to make sure that we follow up with actions, and that's part of the main purpose of this day. So there's increasing awareness that concussion in older persons is an issue that requires government, research, and clinical action. So what I'm going to do now is I'm going to turn it over to my colleague, Dr. Carmela Tartaglia, and she's an associate professor in clinical science at the University of Toronto. And she also holds the, now I've lost my sheet where it tells me what she holds. My apologies here. She holds the Marion and Gerald Solway Chair in Brain Injury and Concussion Research. She's an associate professor at the TANS Center for Research in Neurodegenerative Diseases at the University of Toronto, and she runs a memory clinic at the Toronto Western Hospital, and she's involved in the concussion echo as well. So I'm actually going to stop sharing my screen and turn things over to Dr. Tartaglia, who will continue to speak for a few minutes.
Hello, I guess I will start sharing my screen. And hopefully,
Participants can now see your application. You are screen sharing. You have started screen share. Emanek has joined the meeting.
okay. Hi, and thank you guys for inviting me to this. As you've heard from Trudy and from Judy, concussions in the elderly and an area of research and an area of interest for me is actually in people who already have neurodegenerative diseases, is often under-recognized, and I think one of the issues is really that all the data that is out there is actually completely inaccurate. And we'll go through why I think some of that. Judy has already talked about the fact that lots of the concussions happening in older people are actually from falls. We probably don't have a good sense of that because these are only the people who interact with the healthcare providers, and that's the only way that their numbers get factored in. Otherwise, we don't even know about them. But lots of people getting into, the database because they've had a fall. But motor vehicle accidents are actually a very common cause of concussion in older people. Actually, 70-year-olds and above have the highest accident rate per kilometer than any other age group except for the young male drivers. So you can imagine that, when people are getting older, and we see this all the time, that there's a lot of people who are getting older. They're a little bit slower. They have a little bit of vision problems. They have a little bit of cognitive issues. They have a little bit of, motor issues, and each on their own are okay. And wouldn't preclude them from driving. But when you start to accumulate these problems, and you may or may not know, but the current assessment for older people from the Ministry of Transportation is actually not very adequate. So this is a growing problem. Suicide is actually very common. So attempted suicide, where people will suffer a brain injury because of a failed suicide attempt. And then, an often underreported phenomenon is elder abuse. And so the concussions and traumatic brain injury that can occur from there are also underreported. And so, the mechanisms of injury are actually biologically important because, the kind of injury you get when you have a fall could be different than what happens when people have motor vehicle accidents. And so, when we're looking at a lot of the data, we don't have a really good sense of when things are mild. So concussion falls under mild traumatic brain injury, where you don't actually see a change in the brain. A lot of the patients who are being included in any of our studies, and even I have to say, if a patient gets admitted, it often must be a pretty significant brain injury, because right now the admission threshold for our hospitals is very, very high. And most people who have a concussion cannot be admitted to hospital. They're barely even seen in the emerge, oftentimes not even recognized. But these are not the patients who are getting into hospitals and rehab. So, we really have to think better how we're going to be able to capture all this information. A lot of the times that patients are getting into our databases because they have a mass lesion. So an older person falls, and maybe if they'd fallen 10, 20 years before, they would have had a concussion, but because they're older, they end up with a subdural hemorrhage. And then in that case, you do get admitted. So what about an elderly person and a mild traumatic brain injury concussion? Issues start right at the onset. That, in the acute phase, there are age-related issues that make it difficult to assess whether somebody has had a concussion or not. And as you know, concussion has no biomarkers, right? So this is all clinical information. And so somebody has to undergo something, and then they have to bring their symptoms to the attention of a healthcare provider. So you could imagine that an older person who has some pre-existing dementia or even just abnormal baseline cognitive function might actually forget that they've had an event. that was
Flora Matheson
associated
to
with changes
everyone.
in their
Thank you for providing the definition
baseline
of
function.
FIM.
They can have comorbid medical conditions or medication side effects that will complicate the accurate diagnosis. So hearing issues, lots of dizziness, especially, it's a common side effect of drug. You have a fall, it could get worse because dizziness is a frequent symptom after a concussion, but what is related to the medication? Is anybody even going to pay attention to the change? And unfortunately, the standard practice today still holds that the Glasgow Coma Scale, the GCS as it's often called, is the standard practice for initial evaluation. The problem with it is that there are changes in the brain that happen when people are older that could affect the baseline assessment. So, whether they can hear, whether they can answer the questions properly.
Michelle
Also,
Dukeman, parachute.
usually those
Sorry, everyone. We are
assessments are done in the acute phase. But the issue is that those assessments might hide the actual extent of the injury, and I'll show you why that can happen. So the brains on the left are brains of young people, okay? The brains on the right are an older person. The issue is that older people, and especially if you have a neurodegenerative disease, but even if you're just older, you have more shrinkage of the brain. That's just natural aging. As of 30, 40 years old, our brains start to shrink, and it's fine. We're able to function, we're fine, but unfortunately, there is shrinkage of the brain and there is more space in the brain. And that means that if you have a fall, and that fall or an accident, and that accident is associated with a brain hemorrhage, which is on the bottom part, you will see that there's on the left side, there's the white line, the white
John Puxty to
part of the bone. But right
turned
next to
on.
it, to the right, is this
Lead
area that is
subject.
not dark gray, is kind of a medium gray. That's all blood, okay? So in a young person's brain, you would see that right away, the effect of that blood would be seen. The patient would get a massive headache, the patient would be unwell, and so you would know about it. On the right, the brain has a lot more time to accumulate that blood before the person would feel any effect. And so sometimes these injuries are actually missed in older people because they seem to be okay initially, and
John
they are
Puxty
not
to
having any
everyone.
issues.
I just
So they're
turned
sent
them off.
home, and then they start to accumulate this stuff. And so it's actually not that unusual for us to do a brain scan and find that somebody has had some old blood in the brain. Okay. And so that's a problem. And we don't really, we don't have a good solution right now, but it's something to think about. So we're missing these in the older people. We're missing many traumatic brain injuries. We're definitely missing a lot of concussions. And there are many reasons for that. Sometimes they are forgotten. Sometimes the person is fearful of telling you that they've had a fall or some accident. We need to know how well a person's cognitive function is. Can they remember if they've had a fall? Can they remember if they've had a car accident? If a person sees unexplained bruises, well, maybe they should be asking, the family, asking the person, how are you getting these? People can have gaps in memories as well. A lot of the medications that people, especially older people, take can, impair your memory. They can cause your blood pressure to drop, which puts you at increased risk of falls, can cause some slowness, which also would put you at increased risk of falls. So the issue is, when I looked in my clinic, I have a post-concussion symptom clinic. I looked at across first 300 referrals, and I saw there were less than 1% in anybody aged over the age of 65. So then I looked through 1,000 referrals, and there were less than 1% in those over the age of 65. I've just told you that there's lots of people having falls, lots of older people having accidents, lots of people with brain problems like Alzheimer's, Parkinson's, who you could imagine are having these accidents and as a result, concussion. Where are those people? It is getting a little bit better. And I have to say that in the last year or two, the numbers for older people getting referred, I have now some people who are in their 80s, highly functioning, have an accident, have a fall, and they're being referred for post-concussion symptoms. But it's still the numbers you can count on hands and feet. This is by no means reflective of what is actually happening in our society. So we actually thought about how do we figure out what's going on amongst people who are seeing older adults. So physicians seeing older adults or those with neurodegenerative diseases across North America. We sent a survey through REDCap to 141 physicians, to 1,400 physicians. Only 141 replied. Mostly they were neurologists, as you might expect, but there were some geriatricians, psychiatry, palliative neurosurgery, emergency medicine. And we just asked them, okay, do you see patients with neurodegenerative diseases? Do you see older adults? Do you see patients who have had falls? And what do you do with this information?
Goldberg,
Do you recognize
CIHR
the
Institute
symptoms of
Aging
concussion?
has left the
And our
meeting.
results were maybe not surprising. So 71% of all the responding physicians either never inquired or inquired in less than 5% of their older adults or those with neurodegenerative about falls. So these are the people who are most risk of falls, and they don't usually ask. 51% never ask or don't even consider it necessary to ask about concussion symptoms after a fall. So even if somebody, mentions that they had a fall, they're not asking about that. And less than 4% actually inquire, like a family member or the patient tells you I had a fall, and less than
Trudy
4%
Sherman to
actually
everyone.
ask about
How do I turn
post-concussion
it off?
symptoms. And so, that means that maybe when you're thinking about a person and, things change, we as physicians who take care of people with, older people and people with like neurodegenerative diseases, when something changes, we ask, well, does the person have a urinary tract infection? Because we know even a simple urinary tract infection can change people and make them agitated and make their cognition worse. So you could imagine what a fall and a concussion could do. 92% of the physicians did recognize that, concussions can have a lasting effect on patients, particularly on mood. They had a good knowledge of post-concussion symptom. And they actually thought that, that the older person or even a person with neurodegenerative disease could actually fully recover from a concussion with the same probability as any other age. Only 50% felt they could manage the post-concussion symptoms, but the problem is that the results show people aren't even asking, even in circumstances where people bring it to your attention that a fall has occurred and maybe a concussion could have happened as a consequence of that. So I think the main issue is that, in older adults
John
and in
Fox
people with
to everyone.
neurodegenerative disease,
Most
you
apps
have
to go
to
to Zoom
consider
conferences,
that there could
accessibility,
be
turn
issues
off
with
screen
recording.
alerts.
It could be that there's, some baseline problems there so that you're not getting the full history, that there could be, a change. And so
Toby Harris
somebody
has left the
getting,
meeting.
worsening of their cognitive function in a timeline that is too fast, where you have to consider that something happened. They can have slower recovery. And inconsistently, some of them have been shown to have worse recovery, although there's some reports that they can do as well. And I think Judy just showed that there's, their line of recovery was parallel. But of course, a premorbid condition can affect outcome, and it's important to know their baseline. So like I said, pre-existing medical conditions could result in worse outcome. And that includes things like baseline depression, baseline cerebrovascular disease, if they're already having trouble with their activities of daily living. And they can be slower because, some people, like older people and patients with neurodegenerative disease like Alzheimer's, they have lower reserve. So of course, their ability to compensate and to get back to a level of function that they had pre-fall could be much more challenging for them. And obviously, when they get hospitalized for any reason, older people do struggle to recover, and that it's because, you know, there's deconditioning associated with that. There are, you know, the cognitive function can worsen. People get delirious. So there are issues when you hospitalize people, but you know, recovery is possible. You know, and I think that we've shown that that older people are more vulnerable to having a poor outcome. But you know, a lot of this data, I think, is important to consider that it was a pretty significant mild traumatic brain injury if people are getting hospitalized. And so, you know, how well a person can do if they have a simple concussion is not clear. But I think, you know, there is potential for recovery, although one needs to be mindful of all the things that could lead to poor outcome in an older person. Neuropsychiatric symptoms post-concussion are very prevalent across the lifespan. Older people are not protected against that. And so there can be, worsening of premorbid psychiatric condition. And since neuropsychiatric symptoms are common in patients with neurodegenerative disease, this is something to look out for. And, the most common ones are depression, anxiety, irritability. There's a big, a high prevalence of depression in post-TBI patients. It's important to screen for this because it definitely will make your cognitive function worse. In terms of treatment, well, you need to make a diagnosis. So you need to look for clues, target all the symptoms. Headache, vertigo, sleep issues, pain. These are common in older adults, are common throughout our society. And so it's important to pay attention to them. Headache will make your cognitive function worse if you're 20, with your 30, if you're 75 as well. Poor sleep, which is common after a concussion, also makes cognition worse and obviously make neuropsychiatric symptoms worse. So, and it's important to prevent recurrent injuries and so assess the cause. It's important to remember that falls can be forgotten, but also, underreported by people worried about losing their independence or taking away their driver's license. Again, there is increasing concern that concussion, a past history of concussion, can increase your risk of Alzheimer's disease, Parkinson's disease, ALS, and other neurodegenerative diseases. And this is coming from, large databases. In 2020, they basically rounded up all the data and showed that even one mild traumatic brain injury could increase your risk of dementia, in your lifetime. And so you could imagine somebody who already has a disease starting in the brain, what a concussion could do and how it might accelerate a process that is already there. And obviously, the more of them you have, the worse that is. So traumatic brain injury actually made it to the list of modifiable risk factors for dementia. And, we usually tell people, well, you can't change what's already happened to you. But if you look at those other risks, you can see that there are things that we can do, like exercise, avoid alcohol consumption, work on depression, diabetes, control our blood pressure, continue with education. So concussion in dementia is often undiagnosed and can be associated with an acute deterioration. So it's important to remember that these symptoms like headache, dizziness, et cetera, could obviously be associated with behavioral issues. And if somebody changes who's under your care, it's, to think about maybe something has happened and they can't really tell you about it. And of course, if they're at higher risk of falling, they can end up with multiple concussions. So to summarize, I think it's important to consider the patient, their circumstances, and the mechanism of injury when you're thinking about head trauma, to recognize that a lot of our patients, actually, their data is not even included. And, when you're thinking about elderly people, there are pre-existing cognitive impairment that you might have to think about, fear or embarrassing of reporting them or reporting these concussions or forgetting. And that there's a vulnerability for persisting symptoms across the ages. And so our older people and those with neurodegenerative diseases, have the same risk. And that's it.
Thank you very much, Dr.
Good
Tatalia.
journey to everyone.
We apologize for this audible captioning. We've been trying to turn it off. I'm a co-host, so I tried to turn it off, but I think it has to be done by the host. So if you're seeing captions and you don't want to see them, along the bottom, at least of my screen, there's a closed captioning that you can tick off, and you can go up underneath that as well to get more
Judy, I
information.
just wanted, sorry, I don't want to interrupt, and apologies, Carmela, for the interruptions. We haven't ever had this problem with the screen reader setting. That is, we're not able to find it on our settings side, but I'm just going to quickly send a test. Okay, so I think it might have been Carmela coming from your end. Now that you're muted, we're not hearing it when it when I send a message to everyone. So we may be okay now.
Yeah, except I heard it even when I was muted. So
Well, it seems to be fixed now, so we'll go with that. So that's great. So what I'd like to do is we have about 5 minutes before we take our break. So if anybody has any questions for myself or Dr. Tartaglia or even Trudy, you know, you can put your questions in the Q&A section of Slido, or I see, you know, they're in the chat. Trudy has said, wonderful to see the volume and quality of data on seniors with concussions. Thanks, Dr. Tartaglia. So if anybody has any questions or comments for us, I think one of the things I want to highlight is that when I was referring to recent initiatives for research and also for clinical, those are just a smattering of some of the examples. There are things happening in every province across Canada. There's lots of stuff starting to happen, and that's why it's great to see so many of you in this call today to work on this issue. So I don't think there's any questions. I'm going to just call out my colleague Matt, who's managing Slido. Is there anything in Slido, Matt?
There were a couple of questions that I already answered in the chat. One was about what is FIM, and the other one was about are we sharing the slides? Those were the only two questions that came up so far.
All right, great. So I think, Ellen, if it's okay, we can have people go on a 10-minute break now. And then when we come back to the group, we will go out into our first breakout room. So Ellen will explain that to you when we come back from our 10-minute break. So Ellen, do you want to go right until 12:10 or a
Yeah,
bit
our
shorter?
people, we can, you know, let us know, is 10 minutes okay for everybody? Or if you prefer shorter, of course, shorter break means we end earlier, but there is 2 45 minutes discussion back to back with a little break in between. So we want to make sure that you get a bit of rest before we jump into that. And when we come back from the break, I'll give you a bit of intro on how that's going to work, and then we will be put in small groups. You don't have to do anything.
All right, everybody. It is 1:55 and it is time for us to start our last segment of the meeting. It looks like everybody is back. So that this next segment, we're going to work on consensus building and priority setting. And we're expecting that it's going to take about an hour. So from 1:55 to 2:55. Obviously, if we come to a consensus very quickly and we say all brilliant things and we come out with a clear action plan, then we'll let you go early. Because as my boss, Dr. Mark Bailey, always says, no one ever complains about a meeting that finishes early. So, so hopefully you had a really great discussion in the 2 breakout sessions. I know my fingers were kept awfully busy typing stuff, notes from mine. So I think we should have a lot to discuss. So, so in terms of consensus building and priority setting, we're actually bringing in someone else to facilitate this group. So if I could have the next slide. So I'm going to introduce you to our grand facilitator, as I've been calling him in our agenda. So Dr. Sean Marshall is going to moderate this discussion. And as you can see on the slide, I'm not going to read all of his bio. You can take a look, but he's a physiatrist in Ottawa, and he's also the clinical and scientific leader for the Living Adult Concussion Guidelines, and he's part of the hub team for the Concussion Echo as well. So he is definitely well versed in the literature and I would say all things concussion. So Sean, I'm going to turn this over to you to sort of get us started on our report back and our grand discussion.
And Sean, I wanted to clarify quickly, when we were in the main room together, so we'll start with a report back in a roundtable format. And so each facilitator will share one key takeaway, their top prioritized solution. And while we're doing that, Matt is feverishly inputting all of the top solutions into Slido, and we'll be able to move on to the Slido activity first. But yes, we'll be starting with a round table first. So if we have a facilitator who would be willing to go first, Matt's going to go last because he's working on Slido right now.
So why don't we go in the order of our groups on the spreadsheet? Keep it nice and simple. So I was group 1, so I'll go first. So you want me to report back on 1, right? That's the requirement?
Yes, so it's 1, and then the next person will be Ellen, and she has to report 1 as well, but it has to be a new one. And facilitators, if both of your key takeaways have already been mentioned by the time we get to you, you can just say they've already been mentioned, because we just want to keep it to new content.
Okay, well, I think I'm going to lead with our second one that we came up with, which is we need to strengthen community supports for older people to maintain fitness in order to reduce falls, and also streamline access to needed treatments and supports. So this would be something that provincial ministries of health would need to lead.
Okay, I'm assuming I'm next. So I'll start with 1 that we had, which was education at national level. So therefore, recognition of a pathway that's disseminated across the board with assessment questions, resources, next steps, all should be in one place, know where the gaps are, and develop a plan accordingly that targets concussion and falls education. And we had a variety of people that it should target, including some in a school, like before they become practitioners and clinicians active. So when they are in school, so that's, I'll just say education at large.
All right, I'll go next. One of the things that we discussed was kind of at the root of a lot of the gaps and challenges are these decisions or policies that are in place that create a cutoff for services and funding at age 65. And we heard something similar from Trudy's story. And so we felt if this might be something that would be important to address if we want to see any change to this. And then it appears to be arbitrary. And we had, share from a clinical perspective that an adult who's 65 to 74, 75 doesn't necessarily need strikingly different services than an adult who is, 50 to 55 to 60. And so we thought that completing potentially an environmental scan to understand where these decisions and policies are in place. For example, we know some brain injury associations, their funding comes with these directives. So where across the country are these decisions and policies in place, and where are these directives? And then, can we do, a literature review, talk to practitioners and experts to create a more evidence-informed rationale for changing the way that this system is set up? And also that it would be important to include older adults to advocate, especially if we're talking to policymakers. And we saw this as bringing together a bunch of different perspectives, and we would need an organization. We suggested an organization similar to Parachute that could act as a convener in a bit of a think tank mode.
So for group 4, our first priority is similar to what's been talked about, but I do have an addition to it because we talked about in terms of guidelines to include screening, assessment tools, pathway directions, but we put that, coupled it with joining the national strategy and supporting Bill C277 and supporting, the older adults component of that to make sure it's addressed and not typical children, youth, and adult focus.
For group 5, we focused on 3. Our top 2 were, the first element was concussion recognition to anyone. So education across the whole society. And the second element was education and training for those qualified to perform an evidence-based concussion assessment and management. So this could be whoever type of doctor, nurse practitioner, psychologist that is actually qualified to do an assessment, they do the assessment right. And for whoever is providing concussion management, they do the concussion management right. And by right, we mean evidence-based care and assessments. The honorable mention on our own was caregiver support, basically, to all across the spectrum of whatever caregivers need. Unfortunately, you have to choose 2, and those are the 2 first ones. Sorry, my group, I had to choose 2. And one thing that came out that was interesting was who should lead this. There was a bit of a conundrum of who actually should lead this because of the lack of a central institution that, like, for example, Diabetes Canada, that they find the money, they do huge awareness campaigns, and they support research, and they support system change, they support evaluation. We don't have that for brain injury across the whole thing. We're too fragmented. So it was a bit of a conundrum of who should be leading this.
So for our group, group 6, not surprisingly, we also talked about education quite a bit. That was one of our main things. But to touch on something that hasn't been discussed yet, one of the major gaps we talked about was older adults with concussions and their caregivers don't necessarily know where to go. There's a lack of knowledge as to what's out there and what they can access. So we tried to come up with a solution to facilitate, to create and promote a platform or like a centralized database that's easily accessible for older adults and for caregivers that has all the services that they can access in one place, and a similar tool for providers to facilitate knowledge exchange with each other and access resources related to screening, next steps, recommendations specifically for the general clinicians and providers in the ER, which we identified as a major gap.
All right, so thanks for the 6 facilitators for those points. And I think actually at this point, Sean, I'll turn it over to you.
Sure, wow. So, obviously, great information derived from those sessions. And I think all striking, some very significant themes. And I understand, and many of these things are long-standing problems. And I think some of them are newly identified. And, again, I think I love the topic. I think it was all said by the fact that there is a U-shaped curve in concussion, the fact the same one we see for driving and collision, and that we have a unique population that deserves some attention. Lots of attention, I think paid attention to the left side of the U-shaped curve and really little to the right side of the U-shaped curve. So I think this great exercise, great thought put into what's been had. My understanding of the next process is in kind of my role or our goal is to kind of have discussion around kind of looking around some of the solutions that have been brought forward. And the idea is to really kind of narrow them down through a voting mechanism. I think using Slido was kind of the plan. I think Matt's doing that. And by doing that, I think it can engender some discussion. And if we can narrow down to those top 1 or 2, then maybe we get some direction on like the how. So it's easy to come down and say, wow, let's agree that's the biggest problem. Well, it's not that easy. You guys have been working out for a couple of hours and also working towards solutions, but then actually probably massaging those solutions because we have the collective will at hand here in relation to kind of ideas. So we have everything from frontline clinicians to academics to persons with lived experience. I think that's kind of the advantage of having this, and again, assembling it all together in one place is very challenging. So I think you guys have figured it out. Slido's up there. You either go to slido.com or you use the image there on your to capture, and go in and vote. And so we can all do that and see what comes up on the voting and see if we can move ahead with that.
Yeah. So can you guys give me like a few thumbs up that you are all in Slido right now, because I will have to change my screen.
I'm in Slido, and there is no active poll in that. Is that
No,
correct?
I know. I'm
Okay.
leaving this
Perfect.
screen so people can scan it. They can access. Once everyone is ready, I see a few thumbs up popping. Okay.
Put the link back in the chat too, so people can use that as well if they haven't gotten to it.
Excellent. So I will run the poll. So it's going to be a ranking. You'll notice that the wording is slightly different from what the note takers did, because I had a character limit on Slido. So, but the content should be there. So you should see a different screen popping up.
Yes.
You want us to move these around in order that we want?
Yep, in order to your preference.
Like move the boxes?
Yep, move the boxes and put inside on the top.
Okay.
At least on my phone is on the top.
On my desktop, if anyone's using the desktop, it's when you click on an option, it labels it as number 1, and then you click on the next option, it will label it as number 2, and so on. So the first one you click becomes option number 1.
And after that, you can redrag them and reposition them if needed.
Yeah, and you'll need to once you're happy with your ranking, you'll need to actually submit it, because up until then you can keep rearranging. So hit send at the end.
I do not see anyone. Oh no, there's one. It's 3 more people probably ranking.
And also in the chat, there's some suggestions of collapsing some of them potentially.
Mhm.
Yeah, it feels like a lot of them could be grouped together because I feel like some are getting ranked. I was starting to group first, and then I had to pick from the groups to do the ranking so that they weren't all the same.
Maybe there is one more person voting, but I don't think it's going to drastically change what we got.
Yeah. All right.
Sean, I'm interested in what ranked as number 1. That's your territory there. Guidelines.
It is interesting. So I think that that is a really good point. So we're, very interesting.
So I think everybody has finished voting. Matt, is there some sort of summary, or is it just really what we're looking at? Because it also seems to me that a lot of them are very close together. I think that's probably because there are quite a few that could be grouped, right?
This is what I can share right now. What I'm working on is exporting it and creating a little graph. Just give me a few minutes. You guys probably can start the conversation. I'll share my screen once I'm done.
Sounds good.
Okay. Well, I think that's great. Thanks, Matt. And I think I'm sure that all of you struggled in these ranking exercises because many of the solutions are good, and it's going to and it's going to be a reflection of the group and kind of our lens and our perspective. It seems to me, just looking at these bars, and again, not sure, knowing that we've ranked them, that the guidelines to include screening assessment tools and pathway directions joining the National Strategy supporting Bill C-277 is one that coming out. Interestingly, strengthening community supports for people to maintain fitness and reduce falls. National pathway recognition disseminated across the board. Education all about concussions recognition, who go for specialized assessment and symptoms. And creating educational programming checklists for healthcare providers to improve assessment and management of concussion in older adults. I'm going to guess that I think that of these, based on what you guys actually, so we're all ranking these. When we had the 6 groups actually present their number 1 recommendation, I think that these were each in their number 1 recommendation. So I think it's kind of, by default, I think it's coming down to, because when I wrote down, these 5 areas were captured within what was presented as important areas for people to focus on with regards to concussion in older persons. And what's a strategy to obviously, 1, address and ideally prevent and mitigate the consequences of concussion. To get things started first, I have the chat up, and I think I can see if there's hands up, and I can have certainly others help me facilitate if I'm not able to see hands raised. But does anyone, my understanding is, I guess the first thing I always ask myself when you see a result on a slide or something like this is anyone surprised? So I guess, is there something that's, critically missing based on the conversation? You've all come out of these groups and these sorts of things. And the first thing I think we always want to do is we've spent a lot of time meeting together in different groups. Each group was, I know that Michelle and the group and the organizers tried to balance them out to give, good perspective to each group. Is anyone really surprised by what's not there? And I see that Don says, although I'm principally an educator, I mostly deprioritize all the priorities relating to education. when we want to change, we sometimes think we can't simply educate everyone to do the right thing, but unless we change the system so that people can more easily do the right thing, then no amount of education can help. I think that's where we're going to go. So I think looking at these top 5 priorities and looking at number 1, I think we're gonna go through the stages of, part of this is how do we operationalize this? So maybe something we want, it may be, low hanging fruit. But I think my job, as described to me, because I listen and try and follow the instructions instead of veer off my own path. I think my job is to kind of really look at, okay, if these are the priorities, is number 1 and number 2 so far they're falling out, we're gonna have to ask the questions is, if we're going to do this, how are we going to do this? Who should lead it? Who's responsible? How are we going to know what are the advantage of it, disadvantage of it? How are we going to know if we're successful? And can we even do it? So, for instance, can we educate every Canadian about concussion? I don't know. That would be a daunting task, but that's not necessarily our goal for today. So, other comments, doesn't address system navigation, the role of caregivers once assessed. Okay, so that's going to be an important one. So this notion of system navigation, accessibility of collaborative care was our second priority in our group. Okay, so these are going to be things that are important, but I love the comment earlier about someone saying, could we collapse them together? So for instance, in relation to, I do know in my experience of working with guidelines, we do have the ability to kind of actually, one, have the ability to provide resource, and to highlight what are the guideline recommendations from, say, an expert group or what the evidence tells us about how things can be managed. And out of a guideline, I've always seen, I think that Judy and others and others who are in this group who work on guidelines with me, I think we can all agree that I always see the guidelines as kind of, oh, here's the information, but the more important part is where's the how to? Like if I say you should use a checklist, I think your guideline has failed if you don't give them that checklist like less than 1 click away. Okay, at least you got to do 1 click, got to do some effort, but it's got to be there. And if it's not there, you haven't helped if you haven't given the resource immediately there. And so I think that's going to be a point that you're going to need to bring up. So I'm doing a bit too much talking right now, but what I'd like to do is I see that Helen has her hand raised, and let's go start there and get some discussion around these first guideline recommendations and these highly ranked priorities and solutions. Helen.
So the education piece was raised in our group, and I see the other groups as well. And it was not because it's not happening, it's not there. It's more so what you just mentioned, Sean, whereby it's not being implemented. So it's like, what is the information that we all agree is the information to share from various perspectives, the patients, the caregivers, the primary care providers, and what is it that we're providing and how is it distributed and implemented? So I think the how piece of education was also very critical to bringing it up.
And I think it's a very good point. Just-in-time delivery. There's a lot of people in healthcare who aren't concussion specialists, like a number of us around the table. That's what we see all day long. And you're saying, like, listen, I do know how my job in physiatry. Yes, I can examine a bursitis or a hip, but I don't do that as often as I do. It's not part of my everyday practice. And what we have to do is respect that many people are seeing concussion. It's so ubiquitous, so common, so prevalent that many people who aren't seeing this. It's interesting because the one thing I can tell you, one thing that came up in the conversation when I was able to watch the great presentations, good information about data was, if you say old people and you say falls, I don't think we think concussion. I think we think broken hip. I don't know what you guys, but I'm thinking hips. And it occurred to me, for education, to me, I would almost target everyone who's got a broken hip or show up at the doctor or fall. We should be thinking concussion. It should be like, it's just kind of the extra check, these certain things that should be kind of melded in there. Because I know I'm always worried about broken hip because they're not going to operate on the concussion, but they will operate on your broken hip. And they're, so very interesting. Carmela.
Yeah, I agree with everything you've just said. And, most of all is that recognition piece. And I think that's the issue when we start talking about guidelines and things like that, is that without increasing awareness, we're not going to get anybody to go to a guideline because they don't actually see it. So if people, like I always say, the eye only sees what the mind knows. And if people are not thinking concussion, like you just said, and they're only focused on that broken hip, those guidelines become useless. And I think the issue with older people there are other things that we have to consider. And some of it is really that people forget, and people are worried about telling you what has happened because of the possible repercussions on their daily lives, on their driving license. And so there's going to have to be a different type of framework in place. And there's a step before the guidelines, which I think is really important for helping detect concussion in older people.
I think you're raising a good point. And what I'm hearing, Carmela, is almost kind of like the hip thing. It should almost be orthopedic surgeons or emergency physicians should be educated that if the patient's presenting with fall, concussion should be brought forward as a possibility. And I guess, and even to further that, I used to say, I don't know what you said, but I used to say, and for my little exposure to sport concussion, which I don't see as much, is, but I do know with acute concussion, the only person who doesn't know they've had a concussion is the person with the concussion. And I don't think that's going to be any different for older persons presenting to the emergency room. They bang their head. You'll see them even bleeding out, and bleeding, and they'll say, "Oh, did I hit my head?" And these sorts of things. So it's very interesting to me. So again, something we have to build in our system. Chantal.
Hi, yeah, I just thought I'd circle back and support that in some of the conversations we had in our group. So for us here in Calgary, we had talked about how can we make it as simple as possible for primary care providers, whether it's in hospital or out hospital in the community, to screen for concussion, particularly in the older adult. And would it be worthwhile to boil it down to 5 questions that you stick on the end of some of these fall prevention screening tools that we have? Or, for us, we use something called Connect Care on the trauma unit. And so, when they're admitted to the trauma unit, is it 5 questions that we just screen in the elderly population just to increase awareness and say, could there be a suspected concussion? And I think we just need to make it easy, right? If we don't make it easy for frontline individuals or primary care providers, they're not going to use the tool and they're not going to become aware. So, sticking just a few questions on the end of some of the questionnaires already being used, and or having it pop up in some of these EMRs to trigger these primary care providers to even just think about it and ask the question. I think that's really important, whether we do it in Emerge, whether we do it in the primary care office, whether we do it on the trauma unit.
I think that's a really good point, Chantal, and I think it's really falling under I'm looking at the side of my screen here, 3 and 4, national pathway recognition dissemination is kind of really building it into an existing system. We can't create a new system, but you can create checks and balances in the system. And I know that Carmela, who's an expert in this, is like interpartner violence with regards to concussion and brain injury. This is kind of things that we need to screen for. So if this was probably less likely the older population, I think I'm maybe not have it quite straight, but I think it tends to be a younger population based for interpartner violence. But we need to screen and look for it and be aware. And it's really about raising recognition, because that really won't come forward. So very good point, and I think that's falling to 3 and 4. And I'm hearing some ideas about how we might do that. We might do that by having when the people present for trauma within emergency rooms or within ICUs to be suspicious for this, and or people are doing surgery. So I think some good ideas there. Great conversation and comments. Don.
Just really a follow-up to Ms. Delbert's comments there, and I put it in the chat as well. It just we need to acknowledge the primacy of primary care family doctors within Canada. On this call, we seem to be mostly folks who are involved in specialist care of one kind or another, and who spend all of our life focusing on these topics. But the reality is that most care of most older people is managed most of the time by family doctors. I don't know how well the family medicine community is represented in this group of experts, but anything that we're doing, I think it's going to be family doctors who are mostly using it most of the time.
I think that's a really good point raised. Like who are we targeting? So for instance, and we're targeting so they can have access to it. And I really like the point that was raised earlier by Carmela, the notion of you can have the guideline, but you got to recognize before you get the guideline. The guideline's only good if you kind of are even on that track. So we've got to get that in the consciousness or the awareness of the primary care providers, probably at critical points within their practice, for people to have that knowledge. I think so. It's going to be a combination. So we said, who are we targeting? I've heard from Don is primary care. Where are we targeting? I think I got a sense that we're targeting critical points where people are increased risk for having had concussion. And that is related to falls commonly, but other traumas that patients may experience. And we need to have mechanisms that allow people to have tools to assess, because that came up in the guideline recommendation, or sorry, in the solutions recommendation. And it also came up in the kind of the conversation. Christine.
Yeah, thank you. I really just want to echo, I think some of it needs to be, we need to start maybe simple. Like I really like Chantal's comments about the questions, but also simple on next steps too. So if we're thinking family care doctor or primary care doctors, you know, other places, like what are the simple referrals to make? Even things like optometry and vision assessments, because optometry sees falls with vision loss, but we don't always think concussion either from an optometry perspective. So there's another primary care provider that sees a lot of elderly patients that we could tackle and collaborate and work together to work through messages. And perhaps, you know, if we're seeing a fall, they need to see their GP as well, or they need to see their eye doctor, or what are those, you know, that frontline group that patient really needs to move through as an initial assessment.
Thanks for that comment, Christine, because it really raises another comment too, because we're, you know, in the idea of this, when we look at, for instance, I'm going to say we often have, I know in Ontario, I'm not familiar with other provinces much, we have geriatric assessment teams, right? And are we incorporating those teams? Because you're saying, okay, optometry, and I'm thinking of the nurse who goes into the home, or the OT who goes into the home to look at the assessment. Are they versed? Is concussion even on their checklist? I don't know. Like, is there any, you know, in relation to fall or, you know, injury or symptoms? So it's very interesting to incorporate, I guess, infiltrate into existing mechanisms that are there for for elderly. Interestingly, while I think the slides are changing, that there's three things that I heard that we're kind of looking at. One is this notion of the infiltration, not education necessarily, but a targeted process that allows for education or identification within existing systems is kind of the theme I'm hearing. Second, I heard is guidelines that would be kind of hopefully matching the resources that people would need. But the other thing that was interesting on the second one is this notion of community supports for older people maintain fitness and reduce falls. And I'm going to go to John next, but I'd love some discussion around that thought, because I think of two groups. It's interesting. Who's the most likely to you know, have a concussion? Unfortunately, it's the very frail elderly. They're the ones who are more likely to break their hip. But on the other hand, we also, I'm seeing in my practice, certainly I see a lot of elderly people. I see the 70-year-old who has a subdural who is on bicycling. You know what I mean? They fall off their bike and they kind of get this sort of thing. Or I see the very active person. We say they're older, but the 65 to 80 group is a kind of young old, not old. And we're kind of talking about all. And we have a very active population, and we need to take them into account. How do we identify that? So I just wanted to throw that in the conversation. And John, comment.
Yeah, actually, he's just stole some of my thunder. As an internist geriatrician, I was going to make that point that I very clearly distinguish between young old and old. But I make my young old 55 to 75. So as an internist geriatrician, I run a memory clinic, and I'm seeing a lot of people with injuries from things like cycling. They were up repairing their roof and so on, and suffering traumatic brain injury. But the other point I wanted to make is to add to Chantal and Christine's comment. I think there are key points where we could put in some sort of screening questions or questions that raise awareness to the clinician. Falls we've mentioned, but road traffic accidents, elder abuse, occupational. In Kingston, I see a lot of people from correctional services and the military who've suffered minor traumatic injuries and are now presenting with cognitive problems. So if we had those sort of key entry points, we had some relevant questions that could be asked, we can flag it back to the family physician. But then the question is, who do they refer to? Because that's one of these challenges about who, long waiting lists and problematic access to some services, particularly if you're an old. So you're being turned down by the traumatic brain injury. You have to wait for the internist geriatrician to see them, long waiting lists. So a lot of questions, but I think we can start to raise awareness and particularly support the primary care physician by flagging them, but they have to know where to send them, where to get an assessment.
Yeah, that's solving a lot of problems in a large country too, about access, about services, and about managing it. It's a complex one too, right? Because with concussion, which I'll be frank, is brain injury, and it's funny how we kind of we've gone full circle. It's almost like it's a spectrum of brain injury, mild to severe, where we have cognitive and behavioral change and even physical change. And really, that's what we're talking about. It's almost this point where people don't recognize that concussion can have we know they can have lingering symptoms, but how much it functionally impairs people, I don't think is necessarily totally understood, which is what we're talking about today. I think you raised a really good point. And what I heard, so from the three areas that came up are, one, this notion of guidelines, how can they be better served to meet the needs of the older persons? And I think that obviously the group or the collective knowledge here seems, and I'm involved in that, I guess, but seems to feel that there needs to be more work done on that front in relation to serving older people's needs. The one thing I think is kind of collating to a big area is in relation to this, and I've heard some ideas about where we might infiltrate. So we've heard primary care, and it sounds to me like we need to be targeted in what we're going to do. So for instance, different clinics, different points of opportunity where we might have questions, and we might integrate this into the existing infrastructure for older persons. John suggested 55 and above. I think that would be difficult in some areas because 65 seems to be a set in stone. Although interestingly, in your commentary, I think there was some frustration with the notion of this age line definition of 65. Because I know it goes both directions. Services are not accessible to anyone who's under age 65 who might benefit from those services over age 65. For those over age 65, and vice versa is what I'm hearing in the rubric of concussion. If we are to move ahead, Carmela.
Oh, actually, this was a response to your question about where to implement the recognition of concussion. And I agree, primary care, emerge, long-term care facilities. I mean, there's some low-hanging fruit where there's a lot of patients, fall prevention programs. There's community programs. There's a lot of already programs that gear their services towards older people. And so starting with those people might be a way to at least start to make an impact.
I think that's a great start, Carmela. And I think what you start to do is identify that older person infrastructure of the higher risk population. And what we need is, similar to what Chantal was saying earlier, what are those questions that we want incorporated in there, like on this tick list, this recognition? We don't want to pretend it's all about concussion. When they got a broken hip, let's agree, that's a pretty significant thing. The problem is, if life were only so simple, you have one thing, but we often see it. In my experience with polytrauma, for instance, and I definitely see this in an older person. I have a patient admitted to my old unit. She had a severe traumatic brain injury, got missed because she had polytrauma and multiple fractures. And the truth is, there's things that need to be emergently dealt with. And I think that this is what we need to do, is just say, listen, this needs to be watched for, because down the line, this could be, unfortunately, the more limiting factor for that older person is the concussion, cognitive behavioral change, and I think there's a great example in the lecture earlier of from the lived experience of just how much it changes for people and how hard. And I think it's down the line. It's not the hip that bothers you. The hip gets healed. The concussion can have ongoing sequelae. Judy.
So on a slightly different tack, thinking about actions and what to do, my group struggled a little bit with the question of existing initiatives. because my group said, well, what are the existing initiatives? I don't really know the existing initiatives. How does anybody know the existing initiatives? If we want to capitalize on things that are already started and already ongoing, how do we know about them? And so I think when we're talking about these very concrete things that we can do, part of me wonders, are we really sure that somebody hasn't already done that and it's not out there and it just needs to be elevated? My group suggested this idea of maybe we need a registry of QI projects. I mean, obviously it's an easy thing to say and it's a hard thing to implement, but this idea of we're not really connected to know what the initiatives are in this area. And there might be some things that are already being done in this area. Obviously I'm biased. I know what we're doing at the Neurotrauma Care Pathways Project, and we know a little bit of what's happening in other provinces in relation to that. But these quick screening questions that could be added to something, these resources that could be provided, there's probably already things happening. And I think maybe we need to do a bit of a scoping review, so to speak, to really find out what those initiatives are, to know which ones to capitalize on, to make sure we're not reinventing the wheel.
I think that's a really good comment, Judy. Like, I think we do have a suggestion that's probably because we as a collective, you as a collective, have identified this issue as something that brings everyone together. It's not being done well. It's not being done consistently. We can agree. But I think your point was well taken, is that are there pockets? Are there people who've done a QI project? And that's the interesting thing in this day and age. If these QI projects are done, and you'll see one institution doing it and not another institution not having anything that's done. It's done actually driven locally. So I think the notion of, like, because the first question is, how should we lead this, or where should we go from here? And I think we've come to, obviously our team, the team will wordsmith this as to what we're trying to achieve here. But for this point in particular, a scoping review, seeing where people are at and seeing like what's the best practice initiative as an example of where it's been implemented, would be the best way to go. Like, if you can find something and not reinvent the wheel, that's obviously a very positive thing to do, and I highly recommend it. If it isn't, then I think kind of what I've learned from today is that we need to look at what screening questions and where to implement them, and have, and work with probably stakeholders. And I guess coming down to that, who would lead it? Who would lead this project? And for instance, what would be the levers of this project? Like, who would be the stakeholders, the collaborators who would participate in this? And so I guess I'm looking for, when we're looking at the questions of, how do we take this? So we've got an idea. I think any of us could go. So we have one opportunity now for people to jump in the chat, or we have jump to just in our discussion now. What are your ideas about, where to next with this? And then be openly critical. I think that someone raised a very good point. It was Dawn in the chat. We could have a huge education campaign, which may not be successful at all. Like, we could educate everyone about concussion, get into every medical school, every allied health school, and have a lecture on concussion in older persons, and won't necessarily manifest into what we're trying to achieve. So if scoping review, I think, is a very good idea. And that could be led by next steps from this project, this group. Helen?
Follow up on Judy's point. There are some initiatives that have worked well. They just weren't on concussion, falls in older adults. They were on stroke, they were on diabetes. And when we think of cancer management, or usually there's good system navigation for these issues, and it's been done. It's not that it hasn't been done. The issue is, how can we elevate, as Judy was saying, what is existing, but models that have worked for other health issues.
Great. Yeah, good point, Helen. So finding what's existing as a model, and if that's not the case, Helen, you're saying we can look at what other health conditions have used similar strategies for, I guess, dissemination, awareness, because this is about identification. And we could have, like, I think, let's face it, sport concussion recognition tool is a pretty handy thing. You're playing a sport, you had a helmet on, you got whacked really hard. It's a pretty nice setting to probably be applying that. It's not going to be done on the sideline of a senior's home. So it's something that's very different, which we're trying to solve. I have Carmela, then Dawn.
Yeah, I think those are good points, is to really identify, okay, so who's the audience for this? I maintain that, you have to support the people to recognize. So in terms of general awareness, I do think that at a societal level, all people have to be aware that an old person can have a concussion, because actually that information is not there. People are now very worried about urinary tract infections. So in the hospitals, in the long-term care facilities, all over, we talk about urinary tract infections. Well, if you ask people if they had a fall, they think you're talking about something else. So I think general awareness, and then the audience, if the GP is the audience, if the emerge doctor is the audience, I do think we have to provide support for them. It's not so easy. Like stroke general awareness, and I think diabetes also has worked because the general population recognizes stroke now. But the family doctor does not actually do a good job of stroke prevention. They are not supported to do that. And in our stroke clinics, we see that secondary prevention is not done at all. So I do think we have to recognize where the limitations are, and there is going to have to be an infusion of finances and funds for doing this better.
I think a really good point, and I'm going to punch that home a little bit with today, Carmela. We're doing quality at our hospitals. We're looking, you're doing accreditation. You're looking at your outcome measure, your key performance indicators, and guess what ours is for safety? It's falls. But do you know how many times that I've ever seen concussion mentioned in a falls prevention initiative at a hospital? I don't think I've ever seen it, to be honest. No. And I've been across a few hospitals so in my career, so it's interesting to me. Like just even starting there, it's just not what people are expecting. Yet we all know that's the number one reason people have concussion and brain injury in older persons. Don.
Yeah.
Just building on Carmela's comments about increasing awareness and recognition, which I agree is important. We practice clinically in a world of guidelines, so that once I recognize something and once I identify the problem, what do? I turn to a clinical practice guideline to figure out what the next best steps are. And ideally, that's all eventually integrated into my brain, but basically I want some kind of guideline. And I'm not sure that any of the folks we just mentioned, emerge docs, primary care physicians, or anybody else working clinically, I'm not sure we have a good clinical practice guideline regarding management of older people with traumatic brain injuries or concussion. So that's why I'm glad that number one, as we see it on our screen, has come out as number one. And I think a priority really needs to be creation of guidelines, evidence informed. We don't really have the evidence yet, so getting the evidence and then creating the evidence informed guidelines so that clinicians have a basis for guidance for what the next step is. Yes.
I think that's a really good point, Don. I think that within our guidelines, we have, we're exploring older person guideline recommendation. We have to follow the evidence or expert recommendation. But I think more importantly, I think it's the infiltration of other guidelines. I think it's the infiltration of a falls prevention guideline for older persons, that concussion be integrated as make sure that's a recommendation to get some direction in there. Because you're more, if the patient's had a fall, you're more likely to go to the concussion guideline or the falls guideline on how to manage it. So it's really interesting, like this notion of, again, cross dissemination, for instance, because these are multiple or hip fracture guidelines. Should concussion be in those? So for instance, please rule out this. Like these are this cross fertilization. So a really good comment. Trudy.
Yeah. I just wanted to push for the societal awareness on the basis that unless you have lots of elderly people with their family and friends who are going to a doctor or the nurse practitioner or the psychologist or whoever can diagnose, you won't get enough data to then start looking at, is the guideline working? Is this working? Is that working? I think there are a lot of people now that are working in this area. You're going to get good guidelines. I think they're going to slowly migrate out to the right people. But unless you drive home the message that if grandma fell, get her head checked, it's got to be a PR communication across the board, loud and strong, and then you'll get the health data that ticks, yes, concussion. So yes, I love the 5 quick questions that the GP can ask. I understand there aren't enough resources, but you don't get resources and specialists unless you have data. So I'm really on the, most people need to know about this, and it's not just within professional situations like hospitals or seniors care places. It's the general public that needs to drive this.
I will support that, Trudy. I think that it is about general awareness, and interestingly, having been around for some time with concussion, I can tell you that, you know, back in the late 90s, early 2000s, it was a struggle to even identify that concussion existed. And we've come a long time. Even their first guidelines, I literally had to interview people to be on our guideline panel who would actually believe that someone could actually have prolonged symptoms following a concussion, because many people didn't believe it was even possible. I think we're at the next stage. I think we're going to the next stage of recognizing an important population where it has probably more significant functional implications, right? For instance, cognition is a huge factor. And to Carmela's earlier talk, like there's other risk factors to the brain outside of concussion alone, so even more vulnerable to function and independence. So I think your point's well taken. That you're saying, I'm hearing is, yes, we need guidelines and evidence, so then people, it'll help disseminate. But when you're saying a kind of a campaign to make sure that this is kind of common knowledge that this can exist, is what I'm hearing. Chantel.
Yeah, so Trudy, you stole my thunder. But I just have two comments that I want to make here. You know, when I was preparing for this morning, and reading the documentation, I thought, you know, this is a huge, think about how many older adults fall and hit their head. So 1 in 3 Canadians are going to have a concussion, and a major number of those are older individuals. So I think about the stroke campaign and buses going by with the, you know, the 5 signs of a stroke. We have an opportunity here to do something like that too, to, you know, have a very simple way of identifying a concussion in an older individual, promote it that way, but then actually have a string and link it to public education, like on the side of a bus or a bus stop, right? Link that to then what we're asking primary care providers to ask their patients when they come in, and then link that to, you know, what we're asking the care providers in the care homes to ask patients when they fall, or a loved one to ask their mom or dad when they fall, and have that actually be across all domains, and have the orthopedic surgeon. I mean, I don't know about you, but I see lots of ortho patients afterwards who are on trauma, who, you know, they're seeing me because now they have cognitive issues, right? And it's because they hit their head when they, you know, had their hip replaced. So that's one comment. And my next comment is if we do that really well, I think we can then implement that in our education programs. And I would start with our residency programs. I think there's a huge need there. Our nursing programs, our residency programs, our EMS programs. And if we have a simple message to screen these individuals with falls, we can start actually educating there, and then bringing it forward. So those are my 2 comments.
I think those are great comments, Chantel, and I think that you speak. You know, I think the first notion is that what I've heard from people's comments and input is education, but it's really more about probably more about dissemination of just the concept of it. They're not educating, just educating awareness, and a campaign really, through Trudy's point and your point, probably more both at the one was at the kind of the educational level for healthcare professionals to identify, and 2, was at the generic population level, just for people to become aware that this is a significant issue that can affect people and affects older persons more than others. I think what we've got from today is, one, the need for making awareness of concussion more broad, but more importantly, a notion of pursuing how to target concussion becoming part of the usual assessment and identification routine. That was kind of the message I think it came through. And I think Trudy suggested us through a scoping review, just to see, listen, is there something we can already kind of tag on to, or find out from other programs been successful at doing this? And if not, then we come up with our own strategy, and probably it's going to be collaborating. And I think collaborating with the touch points for where people are more likely to present to the healthcare system with concussion, recognizing that people often don't show up. The first complaint is, I've got a concussion. We did hear about even from the beginning introduction from the lived experience. We recognize that our system to manage persons with concussion has fraught with problems. But I think if we can identify this as an issue for older persons, 55 and above, apparently, then hopefully we can get those systems evolved. Interestingly, for concussion, we started off with very little resource 20 years ago, and now we have more resource. And I think that becomes through awareness, understanding of how it impacts people. And I think you have to have traction. And this, I think the coming together of this group is providing that traction in a very vulnerable population with high prevalence, yet neglected. So I think that's kind of where we're targeting next steps. In relation to guidelines, what I heard was that specific guideline attention to this, I guess with the idea of probably emphasizing it. So it might be, for instance, a specific, even a short specific guideline to older persons in concussion. That would at least kind of bring it to its own attention as the separate problem. And then from there, I got the sense of an idea that we would probably integrate this into other guidelines to make it standard. So not only have the questions, but say standard assessment of a fractured hip includes asking a question or reflecting, is it possible this person had a concussion? And then we could actually educate. And even persons who have, I don't know, in the dementia clinic, I could refer to John within a dementia clinic, but do they ask about concussion history in that as a regular routine? I saw from Carmela's presentation, concussion wasn't asked for very often by physicians as consideration. So lots of good information coming up. I recognize that we probably can't cover off everything. I think we're supposed to end around 3. I don't want it to usurp everyone's time. But are there other things that came off? Those are the 3. The other one we didn't delve into as much, which we kind of touched upon with this young, old. And I'll probably, obviously a bit of bias, and that spans, you are who you are. There's old who are young, and there's young, old who are old. But regards to notion of activity, and was there anything else there? Because that's in relation, that's missing on that topic, because we said, how about fitness programs to improve that? That seems to be more in the range of falls prevention, for which we do know there are existing falls prevention programs for older persons. Any comments about that? Because that was the second highest ranked solution. And we didn't hear too much discussion around that. Now, maybe I didn't facilitate well enough there. But any thoughts about that? Judge a person by stage, not only by age. Yes, I completely support that. And that's what I was trying to get at, but not eloquently saying about old being young, old, and being old versus vice versa. Sorry about that, but I didn't mean to offend anyone in saying that. So
it's interesting that there's a group of people who are interested in old people, and we've been together now for 4 hours, and the topic of frailty hasn't come up much. But I think we're all aware that it's not about age, and it's about fitness and frailty. And so in the future, building frailty into all of our assessments and interventions, I think, is essential, because we know that it's going to make a difference whether you've got an extremely robust, fit CFS of 90-year-old versus a CFS of 65-year-olds. So the age is not important. So I just wanted to put a pitch in there for frailty, which is not news to any of us. But I think that kind of addresses also your comments about young, old. It's frailty, not age, that counts.
Absolutely. Good point, Don. And And the other thing I want to comment, and we also didn't come up, it probably came up in your group discussions about risk factors and concussion in the elderly, which is kind of that silent, just like we don't often discuss interpartner violence. The one that certainly I'm seeing in older persons, and certainly not unique to them, is substance use. And it's, again, if we're looking for screening questions and concussion and substance use, that's something that we're seeing more of. So I'm sure it came up with alcohol and other substances. Judy.
So I'm actually just going to take the liberty to jump in because it's 2:57 and we want to make sure to be finished at 3. So I think on behalf of the working group, Alain Gagné at Parachute and myself and our working group, I'd like to thank everybody for coming. And Sean, thank you so much for facilitating the discussion. We got a wealth of information. I think I'd be remiss if I didn't thank CIHR for providing funding to do this. We are going to be creating a summary, and then we do have our executive committee that are going to be working on this. And a lot of you have mentioned in the chat, don't count me out, keep me included, excited about this, want to be involved. So we have all of your emails. We will not forget any of them. So we will reach out with the summary. Don't forget to complete the post evaluation. It's really important for us to have that evaluation. So thanks for the fantastic discussion. Sean, thank you for the great facilitation. Trudy, thank you for sharing your story. I think it was really important to set the foundation for what we're doing. And I look forward to our next steps. So with that, Ellen, do you have anything else that you wanted to add?
I think it's a good summary, and if you have suggestions for next steps, or if you have suggestions of things that you would like to take on or that you see moving forward that you want this group to help you with, just put that in the evaluation and we're open to all suggestions. Thank you, everybody.